would you expect that there will be some kind of abdominal breathing? This development of the upper fixators of the chest may be there because of her sport discipline, but also even if she was weightlifter or, you know, if you row or something, there's no reason why to have the shoulder blades so high. But 16 times a day, lifting them up during breathing, it will help you to develop it even more. And then if you add this kind of lifting or whatever, what do you do? You must do something because you look like an athlete.
I used to swim, play soccer, and run.
Okay. So in all these disciplines, even if you would say running, did it make her this high shoulders and stuff like that? It will basically, because this is her natural pattern, have them high. And she encourages it in any of the discipline, in any movement of the ADL, and the more in some sport. So okay, so definitely 3 months model prawn will be great to train her and place her shoulder blade. So in the prone position. The original 3 months model starts in this position. You can just rest your head and rest for a while. I'm going to talk for a while. So the original position looks like this, prone position, full extension, and it's nice to have the feet like this, so behind the table, so there's nothing like, you know, this, or the legs are really relaxed and extended. This would be the original position. The elbows are at the same height as the ears. So nothing like that, nothing like that. You remember this is how many weeks? About 6, 8. So we need fully developed 12 weeks, 3 months model. If you remember arm lifting test, in some cases, if you use this position, are you happy with the chest? In people with poor stabilizing pattern here, you saw it within the arm lifting test. If you put her or your patient's arm to this position, then what would you expect that the ribs are doing? Exactly. They are pressing against the table as she tries to lift the chest up. Yes? Because of the amount of flexion. So to centrate her, or not only her, but most of our patients in this position, means that you have to make sure that the lower ribs are not pressing towards the table. They're going to be in the touch, of course, but you don't want to, you want them, your patients, to make sure that they're not actively pressing. Where would you see it if they press down? Exactly. You will definitely see salamis and TL junction lordosis. In case, if you, not in this case, but if you see this, if you have someone with stiff kyphosis and lordosis in the lumbar spine, because there's no other chance, if you want to have the arms lifted like this, then there's no other chance than to make lordosis for such a patient. There might be a modification. What would you recommend? And don't say anything. To get rid of the lordosis.
On her knees?
Sorry. Get up on the knees. Very good. It's a very nice modification of 3 months that you put the patient. Can you just come up on your knees? Yes. You put your patient on the knees to developmentally and biomechanically higher position, but it will help you to look after the lordosis, because with this amount of flexion, the patient is not able to escape you. The reason why I'm showing you this is that we have some nice stiff shoulder, chests here, so you may need this position. It's instead of the fully extended one. This modification is also very good for anything else. And we will have the example here too. We will have it on Brian, and we will have it on someone with painful shoulder. I'm gonna say that this position doesn't require such a big amount of flexion, yes? But you already work on a stabilizing function of the shoulder blade because this is closed kinematic chain. Yes?
What if you have people with painful shoulders and like a hip impingement pain, so that's also uncomfortable there too?
Then you only don't go that far.
Got it.
Yeah? Or another modification would be fully extended legs. Use a chair. Come a little bit closer. Of course, it would be nicer to have the table that can go up and down. And the support will be somewhere here and here normally. Yes? Really, you have to play with the body. You have to centrate the segments of the patient as much as possible, but also as much as the structure allows you. Yes? And or the pain. So you can use equipment, just like I used the pillow under the head when I corrected the chest for someone who's, reclinated, I can use this modification. Yes? So these are modifications, but let's see what's the goal for the 3 months. So coming back to original 3 months model prone. Because this is first course, we will start from the cylinder. Her problem is that she has still shoulders way up high. So to help her muscles pull the shoulder blades down without doing this, that is also very common. If you ask a patient, pull your shoulders down, they will do this. Yeah, is that truth? You have to encourage her cylinder. So in this case, you can take her ribs and make sure that she's not pressing down towards the table, and make her feel that she's supporting herself on the symphysis, but without squeezing the buttocks and without hyperactivation of the hamstrings. If she's not able to do it herself, then you have to place the pelvis just like we have placed the chest in the supine position. So I will play with the pelvis. Sometimes, and we were talking about it over there on the last table, you only have to send the patient home with isolated movement of the pelvis. That will be like the first step, because very often the patient have no idea that they can move their pelvis. So slight posterior tilt, but only all the way to neutral. Nothing like posterior tilt. Yeah? So I'm posterior like tilting, but not all the way to posterior tilt. Now when I'm there, when she feels that she's attaching with the symphysis, I can here provoke the intra-abdominal pressure, or in the very first beginning, just to make her breathe into my fingers. This. While I feel the breath, then I can say, and now give me a push. And keep it. And during the push, I don't want to see something like, yes, I want to still keep the spine straight and nice, cylindric shape here. Here I'm helping her with the punctum fixum, and here I'm palpating the pressure. Once I'm happy with the pressure here, it can either automatically help her with centration of the shoulders. If I held her here for a long time, the brain would recognize this centration and would spread the centration all the way to her supporting points automatically. This is reflex stuff, not reflex locomotion according to Vojta, but this is reflex. It has the specific order. If this is centrated, it's gonna catch up. But what I always recommend you, in any position, go and centrate as many segments as possible, because the reaction is going to be much quicker and you can sooner start with some phasic movements. That's what the patient came for. So you keep this pressure, give me nice pressure, good, keep this. Now I can go and centrate the shoulder blades for her. She has to keep the elbows here. Contact is the medial epicondyle. And I'm not only in shoulders, but I'm like, my thumb is on the shoulder from the front side, rest of the fingers are on the shoulder blade, and I'm like spreading the shoulder blades apart, pushing them slightly down, and externally rotating the glenohumeral joint. Relax, relax. Yes. And in this position, I have centrated the shoulder blades for her. And what's the only phasic movement that the baby can do in this position? Lift the head up, exactly. Now, try to do it. I'm not gonna say anything because I want her to tell it. To say, and that's enough. Keep this. Very good. Chin tuck. Perfect. Do you feel that you have to support yourself on the elbows? Like you're pressing the elbows down?
I feel like they are.
They are, yeah. The difference is, if she, and now forget about the shoulder blades, and just lift yourself up, like in lifting test. If she doesn't centrate the shoulder blades, she will only use the extensors, just like what we saw in the extension test, and then her elbows are gonna be easily taken out. So that can be your feedback. Yes? But if you succeed in centration here, correct really her, keep this pressure, and try to extend only from here, from this middle piece. I'm spreading apart her shoulder blades and lift, and that's it now. And keep this. Now, first of all, she's pressing the elbows down, so she has a good punctum fixum. And due to this punctum fixum, you can come here and touch her trapezius, and it's nice and relaxed. Yeah, so there are some, there are some of the feedback that you can see. You can either give her a massage here, or you can functionally switch off these muscles via centration, approximation, and some phasic movement.
Do you want to tell the patient to press the elbows in, or do you want that to happen naturally?
You can, definitely you can. Also, you can play with the periphery, like slightly press against the radial duction and opening of the metacarps and stuff like that. That's gonna definitely help. But for me, I'm training myself too. So I'm like, I'm not telling anything, because if I feel this looks better, then I go and try if she's attached to it. Like, wait for the automatic reaction. Just like, I'm gonna be there. Also, if I let her work there for a little bit longer, and I will be happy with her reaction, we will automatically see that she would go to, I'm not gonna say that, and maybe we will see that. She would do this. We will see. Good. Now lift up. Cylinder. Very good. Don't go that far. Try not to push your ribs down to the table. Really, cylinder. Focus on your symphysis. Even more. Great. Perfect. And now try to imagine that you're elongating. Keep your shoulders as they are. Keep them there. And try to elongate yourself. Just elongate. You don't have to lift yourself. Push against me. And your ribs towards the pelvis. Now you see how she started to shake. And she lifts the arch here and here. Like this. Yes? So, and if I hold her there and make her work harder and harder and harder, it would be even more obvious. But that's what I'm saying. To get the reaction, it would take long. So you can help yourself by centration, asking her for the pressure, but keep the shoulders apart. Yes? So this would be 3 months model. The baby and your client can do really much in that position, except from, for example, isolated rotation 30 degrees each side, which is very good for mobilization of the middle T-spine. So you can ask your patient to lift the head up, very good, spread your shoulders apart, focus on this spot. Also, if you have someone with lordosis here, you can go to the place where you are happy with, or to kyphotic place. You want to stop him from making even bigger kyphosis, and you don't have to only ask him to lift the head up, but you will go down to the biggest place of the lordosis, to the deepest spot, and you would ask him or her to press that point up. So this point down, but this point up. And this is the most challenging part. This down. Very good. And this up. And you feel how challenging this is, right? This up, this. So basically, one finger is here and one finger is here. This finger is pressing down and this finger is pressing up. So what you do, again, you segmentally mobilize the T-spine. Yes? If the kyphosis is here, you want to make the kyphosis straighter. If there's lordosis, you want to make the lordosis straighter again, which means press it to opposite direction. Yes? Because not everybody has lordosis here. A lot of people, especially us who work with hands, we have lordosis a little bit lower down, and then compensatory kyphosis. So here, and then when you are happy with the elongation and everything, chin tuck, shoulders. Press this point down. In this situation, you can make her rotate. And if she is nice and uprighted, she will show you nice segmental rotation, and you will feel that the rotation goes all the way to T4-5. Yes. Sometimes it's also a good mobilization.